A cerebral aneurysm is a thin-walled outpouching of the tunica media of the brain artery. Most occur at areas of pressure, such as the bifurcations of the blood vessels in the circle of Willis. The circle of Willis is like a collateral. It creates redundancies in the cerebral circulation that allows to maintain blood flow if any part is occluded. With a rupture of a cerebral aneurysm, there is usually bleeding into the subarachnoid space. The most common cause of a hemorrhagic stroke is a ruptured aneurysm. So what contributes to their development? Hypertension, smoking, alcohol, drugs, stimulants, aging, atherosclerosis, and etc. As the aneurysm grows, the vessel wall thins and weakens. It can become so thin that it can lead to a spontaneous leak or rupture. I'll mention three types of cerebral aneurysms. One is the berry or secular aneurysms, which protrude from arteries at the points of bifurcation of the circle of Willis. Berry or secular aneurysms are associated with 95% of all ruptured aneurysms. Fusiform aneurysm is a dilatation of the entire circumference of the artery for several centimeters. They rupture infrequently, but are fatal when they do rupture. They can also act as a space-occupying lesion. Not pictured are mycotic aneurysms. Those are rare. They result when the septic embolus causes arterial necrosis that leads to an aneurysm formation. So what does a rupture of an aneurysm result in? A subarachnoid hemorrhage. With release of serotonin, prostaglandins, and catecholamines from the blood, vasospasms occur. Clinical manifestations of a cerebral aneurysm include headache. These are sudden, explosive, worst headache of my life type of headaches. Meningeal irritation with signs of stiff neck pain, photophobia, back pain. Changes in level of consciousness ranging from confusion and lethargy to loss of consciousness and coma. Nausea, vomiting, cranial nerve deficits and stroke syndrome, hypertension and dysrhythmia. Why? Again, from massive release of catecholamines triggered by the hemorrhage. Signs and symptoms of cerebral edema from inflammatory response, and the hemorrhage leads to increased ICP. Well, why would the pituitary gland be affected? Because of its close proximity to the circle of Willis. And it would result in either diabetes insipidus with resultant hypernatremia or syndrome of inappropriate ADH resultant hyponatremia. Management. We need to treat the hemorrhage, prevent rebleeding, and vasospasm. Procedures include endovascular techniques, balloon embolization, coils, and etc. What about medications? Calcium channel blockers have been shown to improve deficits from vasospasm and are associated with improved outcomes. Anticonvulsants may be used to prevent seizure if there is increased ICP, analgesics for headache. Also think about prophylactic antacids and stool softeners to prevent straining. Nursing interventions are going to be similar to the nursing care of a stroke patient. So I mentioned how an aneurysm can contribute to a stroke. Another condition that can contribute to 2% of strokes are arteriovenous malformations, or AVMs. They are a congenital tangled mass of arteries and veins lacking capillaries. Blood is shunted from areas of high-pressure arterial to low-pressure venous that, when exposed to high pressure, can rupture and lead to a hemorrhage. Therefore, there is impaired cerebral tissue perfusion and ischemia. Manifestations include a sudden decrease of level of consciousness, seizures, if it's a large AVM, headache, visual or speech symptoms, hemiparesis, and progressive neurological deficits. All this are from the hemorrhage, And all these findings are critical assessment findings to report to the physician. In the picture shown, there has been surgical interventions. When blood is no longer shunted, then cerebral perfusion improves. Arteriovenous malformation, incidentally, are usually first diagnosed at the time of intracranial bleeding, usually around 20 to 40 years of age. Remember what the subarachnoid space is supposed to have? That's right, this space only usually has cerebrospinal fluid. With a subarachnoid hemorrhage, there is bleeding between the arachnoid and the pia mater that may result from a spontaneous rupture of an aneurysm, an AVM, or a traumatic brain injury. Typically, the bleeding lasts only a few seconds, so there is only a small total blood volume loss. However, there's also a risk of rebleeding. The blood irritates the blood vessels, meninges, and brain as it hemolyzes, and there is arterial spasms that are triggered by the blood and release of vasoactive substances, further decreasing cerebral perfusion. A classic symptom of a subarachnoid hemorrhage is a sudden onset violent headache. It's typically reported as the worst headache of my life. There can be abrupt loss of consciousness and focal or widespread stroke symptoms, such as motor or sensory changes and speech changes. The headache is different than their typical migraine, so assure that you call the MD. Most people with brain aneurysms do not experience any symptom prior to the onset of the sudden rupture. 40% experience sentinel headaches days or weeks before the rupture, and that is thought to be a warning leak. Diagnostics of a subarachnoid hemorrhage are typically clinical manifestations, CT scan. Keep in mind that sensitivity decreases with time after the initial bleed. So in the first 24 hours, it can have 100% accuracy, but not after. A cerebral angiography can be the gold standard, and lumbar puncture. However, not if there's increased intracranial pressure. So be attentive to signs and symptoms such as headache, nuchal rigidity, and projective vomiting. The challenge is going to be to increase the blood pressure in order to open the vessels, but avoid risk of rupture. To increase cerebral perfusion, calcium channel blockers are used in order to dilate the vessels. Management is always going to include ABCs. Stabilize the patient, minimize rebleeding, and manage vasospasms. Typically, vasospasms occur 3 to 4 days after the rupture. Lastly, surgical intervention if anatomically and technically feasible. Let's talk nursing care. Nursing considerations for a subarachnoid hemorrhage include very close monitoring, aneurysm precautions. And aneurysm precautions, especially during the acute phase, is going to include avoiding of any stimulus. Stimuluses can increase ICP. So provide a quiet, darkened, private room. Keep them calm. Minimize pressure. Well, what activity can they have? None. They need to be on bed rest. What about the head of the bed? That's right, 30 degrees. And visitors? Well, the patient needs their family. However, we need to restrict visitors and make them short visits. Again, less stimulus. Avoid straining, isometric contraction, and use of Valsalva. All of those contribute to increased ICP. Think about analgesia and closely monitor for any neurological change, even if the patient looks good. Family and patient needs support and education. Let them know why you're doing what you're doing, so provide rationales. Rehabilitation is going to be similar to a patient with ischemic stroke.